Hi, I'm Jennifer Weiss, a gastroenterologist at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. I have been asked to discuss with you a poster that will be presented at the 2011 DDW Saturday poster session titled Mortality Differs by Stage for Right versus Left-Sided Colon Cancer, Analysis of SEER-Medicare Data. Differences between right and left-sided colon cancers have been of much interest to many researchers over the past decade. For example, right-sided cancers are more often exophytic, have high microsatellite instability, CpG island methylation, and are more often diploid. While left-sided cancers are more often infiltrating lesions, present with obstructive symptoms, have chromosomal instability, and are more often aneuploid. Analysis of tumor specimens have also shown differences in gene expressions between right and left colon tumors. However, it is unclear if these biological differences translate into meaningful differences in mortality. Two recent studies, one published in 2008 in the Annals of Surgical Oncology and one published in 2010 in Diseases of the Colon and Rectum, both reported an increased risk of right-sided colon cancer. But both studies were limited in their ability to adjust for patient characteristics and reported conflicting results by stage. The aim of our study was to use the SEER-Medicare data set to re-examine the relationship between 5-year mortality and tumor location, and to determine if this relationship is consistent across stage groups. Using the SEER-Medicare dataset allowed us to adjust for a wide variety of patient, disease, comorbidity, and treatment variables that were not incorporated into the previous studies. We identified Medicare beneficiaries from 1992 to 2005 with stage 1 to 3 primary adenocarcinoma of the colon who underwent surgery for curative intent. Chi-square analysis and two-way ANOVA tests were used to compare frequencies of patient disease, comorbidity, and treatment variables between tumor location. Adjusted hazard ratios and 95% confidence intervals for predictors of overall mortality by tumor location within stage and across all stages combined were obtained using Cox proportional hazards regression. We included approximately 54,000 patients in our study. 2/3 had right-sided cancer and 1/3 had left-sided cancer. Patients with right-sided cancer were more often older, female, have tumors diagnosed at a more advanced stage, and have more poorly differentiated tumors. These results were also shown in the previously mentioned studies. After adjusting for multiple patient, disease, comorbidity, and treatment variables in our study with Cox regression analysis, we showed no significant difference between overall 5-year mortality and right versus left-sided colon cancers in all stages combined or stage 1 cancers. Within stage 2, right-sided cancers had lower mortality with a hazards ratio of 0.92, and within stage 3, right-sided cancers had a higher mortality with a hazards ratio of 1.12. Our results for all stages combined differ from the previously mentioned studies. We believe this is the case because we were able to adjust for additional significant factors such as patient comorbidity and adjuvant chemotherapy. We also had a more homogeneous sample. We also highlight the fact that the relationship between tumor mortality and location is not consistent across stage groups. More specifically, it is stage dependent. We hypothesize that this is the case due to tumor biology, and more specifically, microsatellite instability status. MSI tumors are more often seen on the right side and in stage 2. These tumors are also less likely to be associated with lymph node and distant organ metastases. Further research needs to be done to confirm this hypothesis, which, if confirmed, may significantly impact treatment decisions regarding patients with right-sided colon cancer.